So this is a topic which I would say might touch upon in all other fields, what you guys were talking about in endoscopy, in endophthalmitis, or trauma, or any other conditions. Attachment is something which you can encounter in any of these situations. But usual visualization is something like what we are seeing here. But because of the hazy media or whatever reasons, you are not able to see the retina. So where does an endoscope gives you an advantage, as we were still discussed about in hazy media? So that is something which has been taken for granted. Whenever there is a corneal opacity, you can't see, so you will say that fine, we'll use an endoscope, we want to see better. Like in endophthalmitis, or like what Vivek had shown, or the cases where there is, Mudit was showing of cases where there is too much of a corneal scarring and things like that. So, but other than this, I will touch upon the other three factors which we are looking at in cases where we might still encounter retinal detachments, and you use endoscope as an adjunct rather than cases where you use only endoscope to do a vitrectomy. This is an example which are cases which I was talking about, where you have a good visualization of the posterior segment. Still, is there a role of an endoscope in these patients? So those are the situations where you can visualize the vitreous base, anterior PVR, and microcorneas. So this is what I'm going to touch upon right now. So this is what Mudit has shown, where the hazy media, where you can actually see what's happening inside and things like that. So this is one of the case where you can see the hazy cornea and you see inside using an endoscope, and you see a break in the periphery, and then other retina is completely still attached. So that's one example. So that I will not go much into detail because that's what most of us will talk about. But the one point which I wanted to emphasize upon is, see this video. Are you able to see the vitreous more clearer here than what you usually? This is a clear vitreous, which is usually not that common, not easy for us to see. But using an endoscope, this is the view of the clear vitreous when you actually can get. So this is what Mudit was talking about, but this is exactly how you get an advantage of using an endoscope and still be able to visualize the residual vitreous in the periphery and the vitreous based debulking. It is more useful in those situations. We have not stained it with any triamcinolone, nothing. It's just a clear vitreous, and you are able to see little more than what we usually would have seen by using a regular visualization system. So media clarity is still there, but still you can use an endoscope as an addition. So that's what these guys have shown in cases where you use endoscope as an addition. You'll be able to clear vitreous more than what we usually used to do. So that's an advantage of using an endoscope as an adjunct in cases with retinal detachments. And second application where the visualization is still clear. This is the case where we were doing vitrectomy and you see that the retina is still not settling, and you feel that there is a light pipe chandelier which had kept it was not showing well. So if you look at it back again, so this whole retina is pulled up to the ciliary body, and you can actually see the anterior PVR being dissected here and releasing the retina from the ciliary body, and then getting that anterior PVR relieved. So this is another area where it actually helps in identifying first and treating this anterior PVR better than what we could have done with a regular visualization, which is already there. So these are the cases where you have a good visualization, you are able to do vitrectomy, but you feel that the PVR is much, and then most of the time what we'll do is, okay, it's not settling, I've cleared off all the membranes, why is the retina not settling? We feel that there is a contraction of retina, maybe that's the reason you would end up cutting the retina. So this would reduce the amount of retina which you might end up cutting. So you'll be able to identify those areas, and especially in RDs with PVRs where you feel that the periphery cannot be examined with some corneal opacities, and maybe in IOL where there is little haze because of the PC opacity in the periphery. All those cases where you wanted to see the periphery better than what you were seeing before. There's an advantage of having an endoscope using doing a retinal detachment surgery. The third important use is, which I was talking about, is having a microcornea. So if you see this case, this is like 5 mm cornea actually. So this is you can still do with retinal detachment surgery using this because you still have a 5 mm area, because most of these cases have cataract. You usually end up doing lensectomy, and they'll have colobomas, and you will not have much iris there, so you can use the whole corneal area as a pupil for you to see the retina. But the problem with this is, if you look at, you will end up putting sclerotomies closer to this. So if you look at this, so see, this is where you have put a sclerotomies, and the whole area is almost like 10 millimeters from here to here. So that becomes difficult from the center to here. It's almost like even less than, if you put a biome lens here in between, all your instruments are touching your biome lens edge. And the moment you want to move a little, then you're going to move your lens, and that would result in moving of the image, and then it goes off to the periphery. And then anytime you want to see the periphery, you move it, and then that goes off this view. So if you look at this, so at this area, if I was trying to, this is just showing a lensectomy for this patient where I was doing it. So the moment I try to get there, see, the image is going off the center. So I still try to get it back, and then when I move, then you can see the haziness which is coming up, and then you try to move it. So that's where you have an advantage of an endoscope. And so if you, so when you see here, so till now I was struggling hard, and when I changed over to an endoscope, so that's the view. So there is no movement, and you can actually see everything clearly, and you're able to manage things better. The moment you want to see the periphery, you can actually go back and see the periphery there. You can see the vitreous also clearly seen here. So that's an advantage of using an endoscope, where you will still be able to see the posterior pole and other areas. And the moment you want to go to the periphery, you are finding a difficulty. So that's an advantage of using an endoscope in these cases. But like everyone was talking about, the main thing that you need to worry about is lack of stereopsis. So whenever you are doing a retinal detachment using this, so make sure that you're not too close to the retina with a high suction. And like what I was talking about, always keep your instrument in your focus. And you see, there might be a little difficulty in going closer to the retina, and you have a little depth perception problems. But then that can be overcome by having a practice. So it should not be an issue. And orientation is, and again, the second one which you need to worry about. Whenever we are going in, if you move your hand with an endoscope in where the endoscope is in, just a rotation will change the orientation completely. So that's something which you should keep in mind, to keep that hand stable, so that you will not have rotation of the instruments, and then you will not know which side you're going. It becomes like an indirect. You're going in one direction that might go in other direction. So those are the disadvantages of doing with an endoscope. But these are some things which can be overcome, and then it will definitely add value to your surgery. So that's all from my talk for endoscopy in retinal detachment surgery.